Today we will start GIT pathology. The gastrointestinal tract's normal layers are: first is the mucosa which consists of epithelial layer and the lamina propria and the muscularis mucosa. Mucosa is the innermost layer present in the gastrointestinal tract, and then there is submucosa having submucosal glands and the Meissner's plexus. The muscularis propria consists of inner circular layer, outer longitudinal layer, and having auerbach's plexus between the inner circular and the outer longitudinal layer. And there is outermost layer of the gastrointestinal tract known as serosa. Then the serosa is absent in esophagus except for the intra-abdominal portion. The submucosa is the strongest layer of GIT, which have submucosal glands and the Meissner's plexus. The submucosa is the strongest layer of GIT. It provides strength to intestinal anastomosis. Esophagus is muscular tube almost 25 cm in length in adults and 10 cm in newborn. Taking the food from oral cavity into the stomach, as we all know, the esophagus is having 4 constrictions. The cricopharyngeus constriction, which is present 6 inches from the incisor teeth. The aortic arch constriction, which is present at 9 inches from the incisor teeth. Then there is a left bronchus constriction, which is present at 11 inches from the incisor teeth. Then there is diaphragmatic and the lower esophageal sphincter constriction, which is present at 16 inches from the incisor teeth. So this is 6, 9, 11 and 16. 6, 9, 11 and 16 constriction inches, okay, from the incisor teeth. The constrictions are cricopharyngeus, aortic arch constriction, the left bronchus constriction, then the diaphragmatic and the lower esophageal sphincter constriction. The calcifying epithelial odontogenic tumor is called Pindborg tumor. The calcifying epithelial odontogenic tumor is known as Pindborg tumor. There is a presence of functional sphincter at the lower end of esophagus, which prevent the reflux of the gastric contents back into the esophagus. Now there is a disease known as Achalasia Cardia. Achalasia Cardia is characterized by loss of ganglion cells in the auerbach's plexus. Auerbach's plexus, which is present in the muscularis propria layer between the inner circular and the outer longitudinal layer, the auerbach's plexus is present, and the Achalasia Cardia is the disease characterized by loss of ganglion cells in the auerbach's plexus. The cause of this disease may be unknown, the primary achalasia, or it may be due to secondary cause like Chagas disease, which is caused by the T. cruzi or the varicella zoster infection. This result in incomplete relaxation of the LES This result in incomplete relaxation of the lower esophageal sphincter and increase resisting tone. This result in incomplete relaxation of left esophageal sphincter and the lower esophageal sphincter and its increased resting tone. There is selective loss of function of inhibitory neurons, like those secreting vasoactive intestinal peptide, the VIP. There is loss of function of inhibitory neurons, like those secreting vasoactive intestinal peptide and the nitric oxide, whereas the cholinergic innervation is intact. It is characterized by triad of incomplete LES relaxation, the lower esophageal sphincter relaxation incomplete, and the increased LES tone and the aperistalsis of the esophagus. Okay, the Echolasia Cardia is characterized by triad of incomplete lower esophageal sphincter relaxation and increased lower esophageal sphincter tone and the aperistalsis of the esophagus. The clinical features include progressive dysphagia, difficulty in swallowing increases with time as the disease progresses for food, though usually dysphagia is more for the liquid food as compared to the solid food particles. The CCK test causes paradoxical increase in the lower esophageal sphincter tone in Achalasia Cardia. Now the screening test. The cholecystokinin, the CCK, cholecystokinin normally causes a fall in sphincter pressure because of the relaxant effect of inhibitory neurotransmitters like VIP and the nitric oxide. But in Achalasia Cardia, it causes paradoxical increase. In Echolasia Cardia, it causes paradoxical increase in lower esophageal tone, the loss of inhibitory neurons. The diagnosis is by a subarium swallow shows the bird beak or the rat tail appearance of the esophagus due to normal upper esophagus with tapering in the lower part. The manometry is the most confirmatory investigation. The gastric bubble is usually absent in the chest X-ray. The treatment is medically managed with botulinum toxin. The Echolasia Cardia is medically managed with botulinum toxin, but the treatment of choice is surgical excision of the muscle of the lower esophagus and the cardia, the Heller myotomy.